Okay, let's be honest. Trying to figure out which antibiotic to use can feel like you're trying to crack a secret code, right? Especially when you're staring down a superbug. Well, today, that's exactly what we're going to do. We are taking this super confusing list of drugs for MRSA and turning it into a simple, straightforward playbook. Think of it as your guide for making the right call when it really counts. So, let's get into it.
All right, first things first, you've got to know your enemy. And in this fight, our opponent is one of the baddest bugs on the block, MRSA. So what is MRSA? Well, the full name is methicillin-resistant Staphylococcus aureus. I know, it's a mouthful, but the important part is right there in the name, methicillin-resistant. This is a type of staph bacteria that's basically learned how to shrug off some of our go-to antibiotics. It causes these really nasty, tough-to-treat infections, and that right there is why a special playbook is absolutely essential. So when you're up against a bug this tough, what do you even have in your arsenal? I mean, what are the weapons we can actually pull out to fight back and win?
You know, every good game plan has a go-to first move, right? The reliable opener. In the fight against MRSA, for a long time, that move has been an antibiotic called vancomycin. It's the old-school, reliable workhorse.
Yeah. For decades, if a patient came in with a really serious MRSA infection, and I'm talking about the scary stuff, like bacteremia, which is bacteria in the blood, or a really bad pneumonia, vancomycin was the first thing you reached for. It was the trusted first-line defense.
But here's the catch. Vancomycin comes with a classic trade-off. On the one hand, yeah, it's great at killing the bug, and it's not super expensive. But on the other hand, it can be really tough on the kidneys. Plus, you have to give it through an IV and constantly check blood levels to make sure you're not doing more harm than good. It's high maintenance.
And then there's this number. This number changes everything. It's called the minimum inhibitory concentration, or MIC for short. Basically, it's a measure of how much drug it takes to stop the bacteria in its tracks. And if the MRSA you're fighting has a vancomycin MIC at this level or higher, well, your workhorse drug is probably going to fail. It's a sign that the bug is too strong. And that's your cue. It's time to change the game plan fast.
Okay, so what happens when Vanco is out? Either because it's too risky for the patient's kidneys or that MIC number is just too high. Well, that's when you call in the heavy hitters. These are your specialized second-line players, each with its own unique skill set.
First up, we've got linezolid. Think of this one as the lung specialist. If the main fight is happening in the lungs, we're talking MRSA pneumonia, linezolid has a serious home field advantage.
So let's look at the stats. Number one use case, MRSA pneumonia. Why? Because it gets into the lung tissue way better than vancomycin does. The key advantage, and this is a game changer, is that you can give it as a pill, and it works just as well as the IV. That is huge for sending patients home earlier. But, and you got to remember this, there's a critical warning. Use it for more than 14 days and you run the risk of bone marrow suppression, so you have to be watching for that.
All right, next up in the arsenal, daptomycin. I want you to think of this one as your rapid response specialist. When you need to knock out the bacteria and you need to do it fast, especially if Vanco isn't cutting it, daptomycin is an incredibly powerful choice.
Yeah, its main advantage is all about speed and power. It works incredibly fast, and it can take down even those tougher MRSA strains with high vancomycin MICs. This makes it a go-to for really severe infections, like in the bloodstream or for endocarditis, which is a super dangerous infection of the heart valves.
But, and this is a big but, daptomycin has one fatal flaw. One thing you can never forget. It does not work in the lungs. Why? It gets completely shut down by something called surfactant, which is the natural lining of our lungs. So using daptomycin for pneumonia, it's literally like sending a firefighter to a 5-alarm fire with an empty water hose. It just won't work. It's the perfect example of why knowing where the infection is matters so much. Okay, our next player is ceftaroline, and this one is pretty unique. What makes it so special is its family. See, it's a beta-lactam, which is the same antibiotic family as penicillin and all its cousins. But here's the kicker. It is the only beta-lactam that actually works against MRSA. It's one of a kind.
You can think of ceftaroline as a kind of multi-tool. It's a great option for nasty skin infections and also for community-acquired pneumonia. And its biggest claim to fame, of course, is being the only member of its family that can take on MRSA. Now, the biggest drawback, you might want to sit down for this, the cost. It is not cheap, and that can be a real hurdle.
All right, so far we've been talking about the heavy hitters for serious in-hospital infections. But, not every MRSA case is a life or death emergency. So let's shift gears and talk about the options for those less severe infections you might pick up out in the community.
So for something like a skin infection, you're usually looking at a couple of main oral options. First, there's TMP/SMX, which most people know as Bactrim. It's cheap, it works pretty well, but you gotta watch out for things like high potassium levels and skin reactions. Then there's clindamycin. It's also good for skin, and it has this cool bonus feature where it can stop the bacteria from making toxins. The downside? It has a big, nasty reputation for causing a severe gut infection called C. diff, and trust me, you did not want that.
And then you've got the new kids on the block, the long-acting agents like dalbavancin and oritavancin. The big deal with these? Pure convenience. A patient can get just one IV dose and be covered for a week, maybe even longer. This is amazing for treating serious skin infections without having to admit someone to the hospital. But, as you've probably guessed, they have a price tag to match, a very, very high one.
Okay, we've gone through the whole arsenal. We've seen the workhorse, the heavy hitters, and the niche players. So now for the most important part, how do you put it all together? How do you pick the right drug for the right patient at the right time? Well, this is the master strategy, and it's all based on the official guidelines.
And here it is, your clinical cheat sheet. Let's run through it. For infections in the blood, like bacteremia or endocarditis, your first choices are vancomycin or daptomycin. If the fight is in the lungs, pneumonia, you're choosing between vancomycin and linezolid, always remembering that linezolid gets into the lungs better. For serious skin infections, you have a few options depending on the situation, but the most important rule on this whole page is that last one. If the vancomycin is high, you have to switch. Vancomycin is off the table. You pivot to something like daptomycin or linezolid, no exceptions.
And let me just hammer this one final point home, because it is so important. If you decide to use vancomycin, you absolutely must monitor those drug levels. This isn't just a good idea, it's mandatory according to the guidelines. Getting this right is the difference between the drug working or failing. And honestly, it's the difference between a safe treatment and a dangerous one.
So there you have it. That's the playbook for fighting MRSA as it stands today. But it leaves us with one big looming question, doesn't it? This whole strategy is based on the tools we have right now, but bacteria like MRSA are smart. They're constantly evolving, constantly figuring out ways to resist our best drugs. So what's next? What will the next weapon in our arsenal even be? That is the challenge for all of us.